Very good morning. At the outset, I would like to thank the Chief Instructor for including me to deliver this talk. The topic assigned to me is managing traumatic optic neuropathy. As everyone knows, it is one of the potential visual debilitating conditions following trauma. If you see, you have it in 0.5 to 5% of closed head injuries, and the incidence of traumatic optic nerve damages in 2.5% of midfacial fractures and in 10% of craniofacial fractures. The types of injury, it could be a direct or an indirect. The direct is where you have a penetrating injury to the optic nerve, that is as shown in the diagram, and the indirect is following just before the blood vessel, where you have a visibility, what you can find a structural damage which is seen in the fundus, whereas an indirect is the intracanalicula portion which is affected, where the fundus is absolutely normal and you have a vision loss. The pathogenesis of your vision loss here is by mechanical factors. The next is your secondary injuries because of the vasospasm as well as of the edema within the optic nerve. So how do you manage these cases? The management, you have various options available. One is conservative, one is steroids, one is surgery, or a combination of steroids and surgery. So the biggest dilemma is what is the consensus for management these cases. The challenges here is there is no evidence-based guideline for evaluation as well as therapy of traumatic optic neuropathy. And moreover, you don't have a large natural history and a large randomized controlled study which gives a level 1 evidence to substantiate this is the consensus for managing a case of traumatic optic neuropathy. This was an article which was published in the Current Opinion in 2009. So as you see, as traumatic optic neuropathy leads to profound visual disability because of the lack of evidence supporting it, whatever we are managing these cases are only on group level 2 evidence and level 3 with a smaller groups reporting it. So what was the rationale for using a corticosteroids? This reduces the traumatic edema and limits the severity of contusion necrosis of the nerve. This also helps to reduce the degree of vasospasm which accompany the trauma. The various studies which included here, which provided the group 2 evidence is, these patients received IV methylprednisolone 1 gram daily followed by oral steroids for around 11 days for where compared with the placebo patients, and they found that the steroid therapy did not result in any statistically significant improvement in vision compared with the placebo. The next, the NASIS is the National Spinal Cord Injury Study, where they found that methylprednisolone, if it is given in bolus followed by an infusion by 5.4 milligram per kg per hour, they found that there was improvement in the neurological scores which is given in 8 hours. That is the CRASH study which was conducted in 2004. That is the corticosteroid randomization after severe head injury, that showed that there is increased mortality when you give a high dose with traumatic brain injury. So the role of steroids was controversial here. This was only the prospective study which supported the treatment options. One was given steroids, one was given a surgery, and the other was a placebo group. But the final conclusion was neither steroids nor surgery had any benefit in this. So if you see in this study, which was the largest study, I think Yan et al., where they had seen in 1,275 patients, they received intravenous methylprednisolone with optic nerve decompression. They found that best corrected visual acuity improved significantly, but the complications, if you see, there was more of 15 CSF leaks. So the next, what were the next strategy to manage these cases? So they next went on to the neuroprotective therapies. One is the erythropoietin, which is a cytokine hormone which promotes hematopoiesis. This can reduce the apoptosis in neurons. This exerts the protective effects which has been proven in animal models. So erythropoietin studies was a one study, major study which was done here in 2018. They 69 patients received intravenous erythropoietin, and with some of them were also treated with IV steroids. So what they found was, there was no statistically significance between the two groups. The erythropoietin was also a treatment option which was done in Arvind Madurai. They found that both were effective in the management of traumatic optic neuropathy. So the future treatment options are on these to regenerate the axons, protect the retinal ganglion cells. To conclude, there is no level 1 evidence to substantiate a standardized protocol for the management of traumatic. There is a need for large prospective randomized controlled trial. And the research is on new drugs, mechanisms, and techniques which provides new ideas for treating traumatic optic neuropathy. And till you have, it is only on the case to case based scenario where you have to take up the decision to give a steroid or a optic nerve decompression. Thank you.